The first section is on hospital capacity management. Dr. Vanni Agnoletti will be speaking about his section, and I'll yield the floor to him. Vanni, just be sure to unmute your microphone when you speak.
Thank you, Bassam. So we work in a hospital that have 450 beds. Our ICU beds are 17, and we have 18 operating rooms. We started with COVID, this war, the 2nd of March, and we are in the middle. We are not in the front line, but we are close to the front. Usually, we admitted 300 of patients each day in the emergency department. Today, we see 20 patients per day in the emergency department. Half of these patients are COVID positive. So the number of patients is not so high, but all these patients arrives to our hospital. If you consider the number, the total number, today we have 80 patients in our hospital COVID. And the ratio of ICU patient is 10%. So today we have 8 patients COVID in ICU. But this is a war, and we have received other patients from other cities. So we have 15 patients in ICU. Now we have 4 patients out of ICU because we treated them and we want to send them back home. The average number of ventilator days are 15, 20. And the length of stay in ICU is probably 20 days. We started with only one room with negative pressure. And we use not artificial, but natural pressure, because outside is cold, and we didn't know how to create a negative pressure. So we opened the window, and like a temperature gradient, the temperature, so the air can follow the flow from inside to outside. We didn't know what to do. And today, believe me, is not a problem, the negative pressure. We don't know how many patients are getting discharged every day because we don't have enough number, probably 1 or 2 per day. I'm talking about COVID positive. We didn't know what to do at the beginning, so we decided to create 5 more ICU beds far from the normal ICU. So we have 17 beds for COVID patient and 5 beds, ICU beds for no COVID patient. We reduced the surgical activity of 80%. We are a level 1 trauma center, and now, believe me, there are no trauma at all. So we can use these 5 beds for all the city. It's not simple, but we are trying to manage. If I look at me in the back 2 weeks ago, what is important for me now, for us now, is that we don't have a plan for discharging the patient. We thought to put the patient inside of the hospital, and today we don't know how to put the patient outside of the hospital. We didn't think about the post-ICU. We are trying to create sub-intensive beds, but believe me, it's not easy. We were not prepared to think about the post-COVID patient. Thank you.
So
we are, Bassam, okay. The star where we live, and Bergamo is high in the big red circle.
Okay. So Dr. Chu, I think this is a good time to start getting questions from the audience. I'll hand it over to you, Larry.
Thank you. So we are getting some questions in from the audience. I also encourage more of you to ask questions. I also remind you to, when you are sending your questions, make sure to select all panelists and attendees when you're typing in your questions. So here's a question that comes from one of our audience members. What characteristics do you use to determine what operating room cases are elective versus urgent, or to do during this period, pandemic period? Many elective cases are still happening right now in the United States. How do you make that decision?
Yep. We decided to reduce on elective cases and to give priority to oncologic patients. It's not easy. And we try to stay in a period of time of 30 days. So we try to give operation to patient in 30 days for all the surgeons. Every day, only one operating room can work from 8 in the morning to 8 in the afternoon.
I see. And then going back to the period of time before you had the severe influx of patients until today, did you find the number of elective cases was, how were they being handled?
Can you see again? I didn't hear.
How are you handling elective cases?
Now?
Yeah, now and in the immediate period before.
Okay, before there was a scheduling cases for week and for month. So we have to respect all the surgeons have a scheduled operating room. For example, general surgery have, for elective cases, they can use operating room 12 hours a day for 5 days a week, except one day that they can work only 6 hours. Now, in 1 week, they have only 12 hours for surgical procedures. And it's the same for all the for example, for ENT surgery, they have for 1 week only 1 day of 12 hours. So each specialty, all specialties have only 12 hours per week. Monday, for example, general surgery. Tuesday, for example, ENT surgery. Wednesday, breast surgery, and so on.
Another question. Do you have a dedicated team for managing intubations or airways for COVID-19 patients? And how do you manage with a shortage of PPE?
It's a good question. We don't have a dedicated team for COVID intubation. If you need to intubate a patient, every part of my staff, every anesthesiologist can intubate the patient. We follow the guidelines of our hospital, and we don't have a specific. And there's my colleague that after will speak about that. And I don't remember the second question.
How are you dealing with the shortage of face masks and personal protective equipment?
You know,
we are trying to, yeah, there's a doctor, and after we'll speak about that, Alessandro Circelli. But now I can say that we're trying to follow the rules, but it's not easy. Be prepared to manage the fact that you don't have PPI.